Okay, good morning. I think we shall start. Savannah will be the presenter, and as I've said in the WhatsApp group to all my networking, I said this paper is one of the almost perfect scientific paper and research, but it may not be 100% perfect. I think we may know in what area from this MJH. Yeah. However, this is kind of one of the rare gem of scientific paper. If you want to learn how to write a complete and clear papers, this is one of the thing. This is one of the paper that you want to read through and through. It's very clear. If you even the background itself, you will know how to write a background as leading to the objective of this research. Yeah, it's very good, very well written. I would say this something like a Dutch, it's a Dutch kind of culture. They are very kind of perfectionist, and yeah, yeah, they don't mind slow work, but so long it's a quality work. Yeah, so you don't like play with the Dutch. You want to play a lot of papers, very fast working. It's okay, but they put more emphasis on quality work. Yeah, and they believe longer time, taking longer, longer effort is important to produce high quality work. So you can see their work in this paper. Okay, so Savannah, I will pass the platform back to you. So we shall hear how this study affect our practice.
Thank you, Prof. Chu. Good morning, everyone. Today we have this topic for MJH12, the effect of physical therapy versus arthroscopic partial meniscectomy in people with degenerative meniscal tears. So actually, in this paper, they want to compare the exercise given to the subject versus the surgery done by the surgeons in the area of the knee, where they remove the part of the knee, the meniscus area. So this study would like to see either comparison between these two intervention give any non-inferiority effect or result when compared between these two among patient aged 45 to 70 years old. So if you can see here the key points, the finding in this study, it shows that there is no significant or clinically relevant result between group difference in patient in this study. So we will see how is going with this. How is this study going?
So Savannah, can I request you to show your video so that it's more engaging? If you can have the video on.
Video?
Yeah, video of yourself.
Prof, Kak Sawana already showed the video actually.
Is it? Why I
Yeah.
don't see?
Yeah.
Okay. Oh, is it? Why I don't see? Okay, never mind. Go ahead.
Okay. All right, introduction of the study as stated in the paper. It is quite brief actually, but it is stated there the RCT and systematic review from previous study related to the comparison of the APM, arthroscopic partial meniscectomy versus exercise therapy. So APM versus the PT actually, physical therapy in patient with a degenerative meniscal tear shows that has no clinically meaningful patient benefit in first 2 years of follow-up. Actually, a previous study has been done and they only limit the study up to 5 years, but in this study, they extend the study up to 7 years. So 2 years for the primary outcomes and follow up 5 years for the secondary outcome. So previous study related to the condition, it shows that it has no clinically meaningful patient benefit in the first years follow-up, and also it lack of clinically relevant differences in important patient-reported outcomes, such as knee function in 3 to 5 years follow-up. Also, there are debates or conflicts of outcomes related to this topic, which After the surgery, it's been reported that there is likely increased risk of radiographic knee of osteoarthritis, and also 5 times higher risk for total knee replacement, like the treatment for end stage of osteoarthritis after surgery. And also they found that no clinically relevant difference between 2 treatments for OA progression. So actually, from this literature review, they found that actually they still need some evidence to support if what if they prolong this study up to 7 years, beyond than 5 years. So the importance of this study, they want to find the high quality evidence about long-term effect between 3 to 5 years and beyond that. All right, study description. This study is aimed to compare patient-reported knee function using IKDC score questionnaire at 5 years follow-up after surgery of APM and exercise-based therapy in patients with a degenerative meniscal tear. Secondary outcome is they want to assess the progression of radiographic images and symptomatic evidence of knee osteoarthritis reported by the patient. So they hypothesized that the PT or the physical therapy is non-inferiority as compared to the APM over a period of 5 years follow-up. So this study actually RCT study, non-inferiority multicenter randomized clinical trial done by the Orthopedic Research Consortium West in Netherlands. And they include 2 years follow-up, following by 5 years after that, conducted in orthopedic department of 9 hospitals in Netherlands. They include 321 patients aged 45 to 70 years old with the condition, also comes with symptomatic non-obstructive MRI confirmed by the surgeon, by the doctors. They include male and female subject and multi-ethnic. Data collection took place between July 12, 2013, and it roughly ended at December 4, 2020, roughly 7 years. So the intervention, there are 2 arms. The first one is they were given APM, arthroscopic partial meniscectomy, a surgery of removal some parts of the medial or lateral meniscus area near the bone within 4 weeks after randomization, and the other one received exercise-based physical therapy within 2 weeks of randomization. So the inspections, standardized inspection for the arm for APM include the assessment of the lateral and medial meniscus, the anterior cruciate ligament, and the level of chondropathy, and a general classification of the level of cartilage degeneration. Actually, I'm not very sure about this because it's too quite medical for me, but they did some assessment to confirm the condition in the patient. So after the removal of the affected part of the meniscus by the surgeon, the patient will receive written instruction, including a home exercise, what to do and how many times of the visit they need to attend, and how many questions or the how many questions they need to answer for the study. The surgeon only refer patient for physical therapy only if the patient didn't in the case of delayed recovery following the guidelines by the Dutch Orthopedic Association. For the physical therapy, they receive treatments for exercise by the physical therapists, which they need to come to the center, and it consists of 16 sessions of 30 minutes each. The activities includes the if the knee symptom persists following the physical therapy program, the patient need to attend additional physical therapy session with the doctor or the surgeons. From these 2 interventions, cost for the surgery by the APM arms, cost of the surgery were covered by the patient health insurance, while for the PT therapy arms, they will receive compensation because this therapy is not reimbursed by the Dutch health insurance. So one is covered, one is not by the health insurance. So the other one is compensated by the study. For the patient from the therapy group, if they have optional delay APM crossover if the physical therapy treatment has failed for them. So in this study, actually they have 3 arms. Later on, we will go for that.
Yeah, Savannah, I think Prof. Niza is here with us. Perhaps Prof. Niza can comment on the arthroscopic partial meniscectomy. Is it something standard, or is it something they did more than what's the standard surgery here?
Yeah. Hi, doctor, are you there?
Or maybe any orthopedic surgeon around? Okay,
Maybe
perhaps. Yeah,
all right, we continue first.
yeah, perhaps continue first, and then we'll.
Okay. For this study, all patients did not receive any financial compensation for participating in the study. So if you see, this is actually the protocol, physical therapy for the PT arms. There are list of the exercise they need to do at home. They need to do by the physiotherapist. Just now I mentioned, but this is the list of the exercise. It consists of 16 sessions in 8 weeks. So this one also is, I'm not quite familiar with this one. So maybe someone can explain later on about this one, how it improved the condition by having this, movements, right?
Savannah, I think the physical therapy exercise program, as mentioned in the paper, is evidence-based. I think they base it on some proven kind of exercise program.
Oh, all right.
Yeah, it was I think conducted by the physiotherapist, right?
Yeah, it must. Okay, thank you, bro. And then for having the subject in the study, they put the inclusion and exclusion criteria. So for inclusion, patient are aged between 45 and 70 years old, and they are confirmed by visualized MRI having a meniscal tear by the surgeon. They are mental competence, they are willing to comply with the schedule, and they also given their informed consent. For exclusion, there are lists actually, especially for the patient having knee locking, like catching or locking, or having trauma leading to acute surgery, they will be excluded. And then they are having associated injuries on the index knee from A to D. So like a symptomatic partial ACL rupture or any total ACL rupture determined by clinically examination by doctors, complete PCL injury or cartilage change down to bone, or an injury to the lateral or posterior lateral ligament complex with significantly increased laxity. I think doctor needs to confirm this, the exclusion criteria. And the rest is a history of knee surgery other than diagnostic arthroscopy on the index knee. They are having tumors on MRI suspected for cancer. Obese patient with BMI for over 35. ACA 4 to 5 appendix D patient which can interfere with the rehabilitations. General disease that affect physical function of systemic medication abuse like rheumatoid arthritis, SLE, gout, and pseudo gout, or any other medical condition or treatments that can interfere with the completion of assessment of the trial. Also, if they are on drug or alcohol abuse, they also will be excluded. And this patient need to be able to speak or read in Dutch. So this is actually the flowchart of the allocation and randomization. The number of patients, it did mention in the paper that number of patients screened for the eligibility was not available, so they don't have the number on that. And the randomization is based on 1-to-1 ratio and varying block size up to maximum of 6, and stratified by hospital and age. Age is between 45 to 57 and 58 to 70 years old. And it also mentioned that patient, clinician, and research staff were not blinded, except for the radiologists. So the participants at the beginning of the study were 321. So they allocate into two groups, 159 in the surgery group and 162 in the PT group. So at the end, only 139 completed the 5 years questionnaire, and other 139 completed 5 years questionnaire in the physical therapy group. The reasons that subjects withdrawal in this study includes did not respond to the invitation or reminder by the researcher, reason related to knee symptoms, maybe injury, and other than that, receive no surgery but continue follow-up. Some of other patient, like I mentioned previously, that they also go or option for the delay APM later on because the physical therapy didn't give any result on them. So you can see here the cumulative number here from 35 up to finally 52 at the end of the study. So later on they received 52 subjects received the surgery. So the data collection involved at the beginning of the study, baseline, 3 months, 6 months, 1 year, 2 years, and 5 years. Actually, I separate these 2 years for their primary endpoint and the other 5 years follow-up for secondary endpoint. So the study protocol actually includes all of the information about the study. I won't go for that. Maybe later on we need to see something, then I will open on that. For the sample size calculation, it is based on continuous outcome on inferiority trial for the IKDC subjective knee form because the IKDC is the primary outcome. So I entered the information, level of significance for 5%, the power 90%, standard deviation 18, and non-inferiority threshold is 8. Non-inferiority threshold 8 is based on previous study. From the previous study, they mentioned the non-inferiority threshold is roughly around 11 to 11.5, but for this study, they decided to be 8, the minimum number to have the clinically relevant difference for the IKDC. And standard deviation is based on previous study also. Normally, initially they put 20, but later on they changed to 18 after 1 year of the study commence. So they made some changes on that. So they have reduction number of sample size for this study. And then I included 20% loss to follow up and 20% of delay APM in PT groups. So later I got 158 per groups, and total number required for the 2 arms is 316 individuals. So it's quite similar from it's quite similar to the study provided by the researcher in the paper. And then primary outcome, I include both primary outcome and secondary outcome. So it based on patient-reported outcome. The IKDC score is actually a questionnaire, it's validated one. So it based on the knee-specific symptom, function, and sport activity, 0 for the worst and 100 for no limits function. So for this study, the baseline is around 44 something, the score. So is in the middle. So I do not know how to say, but it's in the middle, 44. Secondary outcome measure is include the knee osteoarthritis on radiograph. So they assess by having the Kale-Grant-Lawrence grading scale. Classification is from 0 to 4. 0 is no osteoarthritis and 4 is severe. Also, they include the RC Atlas Sum score to assess the severity of the score based on the image of the radiograph done by the radiographer. Is grade 0 normal to grade 3 is severe change in joint space or osteophytes. Actually, I'm not very sure about the grading system because I'm not familiar with the images and so on. Maybe someone can help with that later on. And then they also see the progression of RC baseline for 5 years. They want to see how much the progression of osteoarthritis in 5 years' time. So it also used the score. Some score of RC range from 0 to 18 on the 6th item. They also have the symptomatic knee OA. So they have the questionnaire again, the OSPS score for 5 years. It range from 0 to 100 for the best and towards the worst physical functioning. And they have the health index, something like that, to have 2 symptomatic knee OA and combined with KL score. If the result is greater than 2, and the OSPS score is 52.8, so the patient confirmed to have the osteoarthritis. So they also get the patient-reported outcomes in terms of pain during activities. So it's assessed for the preceding week from 0 to 100, no pain towards worst imaginary pains. They also have another OSPS score, same as the secondary outcome I mentioned previously. Also, they include the quality of life score, EQ 5T, 5L, based on the mobility, self-care, daily activities, pain, discomfort, and depression, anxiety. And the index score ranges from 0 to 1, from best to best of quality. However, the EQ 5T, 5L was not reported in the paper.
Yeah, Savannah, maybe you can ask the audience if there's anyone like from radiology or rehabs or orthopedic. These questionnaires, I mean, available in Malay or validated in Malaysia. I know that Euro EQ 5D and 5L, I think we have that in Malaysia validated. How about the others? The others tools commonly used in our setting? Do we use any of that tools in this paper in our setting in HPUPM?
Anyone? I didn't check actually. In Malaysia.
At least IKDC, is it common or is it they all commonly use that? Is there any orthopedic surgeon around? Then we will get a more, relevance in this paper.
From the literature, Prof, the IKDC actually is not a gold standard, but is well accepted to be used as a assessment for the knee functions. It is what from I read lah.
Is there any comment from the audience on the tools? Or are all the tools are actually strange to us? I don't hear anything. Can you all hear anything? No, right? Okay. Perhaps we can discuss later on.
Right.
Yeah, okay.
All right. For the analysis 2 years and 5 years, for baseline characteristic frequencies of further surgeries, partial or total knee arthroplasties, patient receive delayed surgery following physical therapy, and secondary outcome for knee osteoarthritis, they put it as a descriptive statistic. And for continuous outcome, they measure using a linear mixed model analysis with a random intercept. This one actually, the information actually they didn't put in the paper, but I tried to guess actually either this one is the correct one. I'm not sure. It includes level 3 cluster level, repeated measure, participant and hospital, independent variable, treatment group, baseline value of the outcome, co-founder. This one was stated in the paper, the co-founder level of OA at baseline using the KL classification, baseline pain during weight bearing, body mass index at baseline, BMI more than the BMI, and also the sets of the participants, and random effect was the intervention effects. So this one I tried to find out, even though not stated in the paper. And non-inferiority threshold of 11 point based on previous study, one-sided alpha level of 0.025, and statistical significance was assessed at the 0.05 level for secondary outcome measure. They also include intention to treat analysis for 2 allocated group for 5-year follow-up study, and also aspirated analysis for 3 allocated group of APM, PT, and PT delay APM. So the other two is also, I already mentioned just now, this one. All right. Before we go for the limitation, do we have anything? Before we go to for the result. Do you have anything to comment or to add on? Oh yeah. Can we proceed to the results?
Perhaps, do you want to say something about the study design, how and why they plan the analysis in such a way? Do you have any understanding on that?
Do you mean by the linear mixed model, Prof?
Yes, the statistical plan.
Okay, basically because this study actually they involve many measurements actually, not only for the radiograph or the accuracy, they include actually many parameter inside this study. Like for this one, they have not only accuracy, they also have quality of life, they have VAS, TAS, PSC, and so on. So that's why they choose for linear mixed model, because they can, combine all the study and then they try to find maybe correlation. So they run all the data at once using linear mixed model. I think because of that.
I think the mixed model is because of the repeated measures
Oh
over.
yeah, yes.
How
Because
about
of
the other statistical analytic strategy? You know, the intention to treat and then as treated. Any
okay,
comment? Yeah.
because this one. All right. Okay, because along the way, they are subject in the PT groups, they are not improving, by the physical therapy. So the option for the third one, delay APM. So that's why it comes to the intention to treat and as treated. Because from the beginning, the allocation groups only two, the APM and the PT, but later on they add on the delay APM. So there are two analyses done by the researcher in this study, to show that it is best actually for the RCT, showing that what's allocate for them and what actually treated for them. So that's the reason actually.
Yeah, the
As
first one is actually intention to treat, right?
yeah.
Yeah, you know, the advantage of doing intention to treat is that you maintain the prognostic factor between the two groups. Whether they get delayed surgery or not, they still keep it in the same group and to see whether the primary outcomes differ or not. But then they know that this may be underestimating the effect of surgery or PT, so they proceeded to the as treated, and then they thought of also there's another group. They got a
Yeah.
they got a PT and then a delayed surgery. Could this group have better outcomes? So they were not sure, so they carried the as treated analysis, adding on another one. I thought in the paper they say another one, and the fourth group, who don't get anything. Is there a
Oh,
fourth group?
no, I don't think so.
Okay, so at least they want to see as treated, meaning patients as what they get, see whether the
Yeah.
outcome differ or not. So which is very, very good planning and very, very thoughtful analysis lah. You want to see whether truly or not the PT or the surgery or the accidental kind of groups, PT plus delayed surgery fare better at the end. Yeah. So it's very thoughtful researcher and analysis lah, to me lah.
All right. Then we go to
Yeah,
the
sure. Go.
okay. For the results, you can see here at the end of the study, only 139 patients completed the APM arm. Same with the PT arm, but there are different number of patients or subjects that withdraw from the study. For this group is likely 11. This one is 19 withdraw, and the other two, this group is 22 withdraw from the study. So okay. And the reason, the withdrawal reason for the subjects will differ due to either they respond or not to the investigation, reason unrelated to knee symptom, discontented with follow-up, reason related to knee symptoms, and unknown to the researcher. So for the table 1, they reported the baseline characteristic of the participants in the study. They include the mean, the SAAS, the BMI information, and also they include the secondary outcome result descriptively in here for the imaging, for the OAR-SI sum score, for the IKDC score, and pain during activities, but they didn't include the information about the quality of life or the result about the quality of life in this paper.
I wonder, sorry, Hasawana, I wonder the baseline characteristics show the knee condition. Is it something mild, moderate, or severe?
From the image, no, there is no, sorry.
Based on the scores?
Only for the IKDC score, baseline is 44. I do not know
No
how
idea,
to,
right?
yeah, because 0 is worse, 100 is no limit on function. So maybe it is in the middle.
Slightly lower than the middle, isn't it?
Yeah, 44 and 46, but it's quite similar.
Quite
But confirmed by the MRI that they are having medial and lateral, affected area of the meniscus. So means that they are having the condition of OA.
Yeah, it's MRI confirmed, huh?
Yeah, MRI confirmed. And then they have also the Kellgren-Lawrence classification of the images of the X-ray. Means that they have no patient have severe OA, but 6 and 5 having moderate, and most of the participant has doubtful, meaning that there are some things related OA related in their bone, in their knee.
Yeah.
Yeah,
But this, the primary condition is the knee. About the knee in this research is meniscal tear, is it? Degenerative meniscal tear. Okay, it's not actually for knee OA, but they also look at whether knee OA is something that related to the meniscal tear. Sometimes one injury to one part can lead to the OA lah. So they look at that as well.
Yeah.
And they have excluded, remember, the exclusion criteria. So they have excluded those patients that definitely require surgical correction or management. So it's like these study samples are, group of patients that may benefit from physical therapy or physiotherapy rather than surgery. So this is a selected group of patients that we want to be very clear about. We don't want to subject patients that require surgery to physical therapy. Yeah, but in this kind of so-called in between groups, not really healthy or mild, but in like slightly problematic, but not really like serious.
Severe.
Yeah, so they did a research, see whether physical therapy is as good or not. Yeah.
Yes. Okay. For table 2, they reported the primary outcome measure related to IKDC score, intention to treat analysis, and for the as-treated analysis. So if you can see from the result, for after 5 years, between mean difference between group is 2.8. Sorry, is 3. Sorry, in the paper it mentioned that over 5 years follow-up, the overall crude between group difference was 3.5, and after adjusting the confounding factor, it becomes 3.8 over here. So this one is for the IKDC questionnaire score for knee function, but there is no between attention. This one is the group adjusted. This one is the mean. Sorry, this one is the crude adjusted. So as compared between before adjusted and after adjusted, there is not much difference, 3.5 and 3.8 difference. But stated in the paper that there are improvement for both group, A, PM, and PT groups in the mean of the IKDC score from 44 to 78. Remember that the baseline IKDC score was 44.8 for the APN groups and for the PT group is 46. So there are improvement, from the accuracy score for both group. Meaning that both the surgery and the therapy basically give a good improvement on the patient conditions. Anything you want to add, Prof, about this table?
It just means that they both improve quite similarly in a similar kind of scale. Yeah.
When we see the result in this table, this one is the crude difference between group different and adjusted. Even they have some improvement on the score, the threshold, the clinically relevant difference or the threshold is 11, but the improvement is still below than that. It means that clinically there is no clinically meaningful for the condition to be improved. How to say, Prof?
Between the groups, there are no clinically significant difference.
Yeah, even it was improved, but still it's not beyond the 11 of point of the threshold. So it's still below than that, meaning that the PT is still was set non-inferior as compared to the APM. Yeah.
Well, they have set that difference scale of 11 points on IKDC, and they want to check in the research whether there's such a big difference. If the difference is more than that, then they will say one is better than the others. But they have proven in this research there is a difference, but the difference is very small. So then they can conclude these two are very similar in terms of on the outcomes measured by IKDC.
Even though they are adjusted for the confounding
even they adjusted for it.
Yeah, still below than the threshold point.
They don't actually look at the point estimate, they look at 95% confidence interval. Even that, only one time point on the adjusted score crosses 11. There's only the time point at 1 year. But all the other time point, the outcome, the difference in terms of IKDC, the difference is less than 11 point.
Yes.
Yeah. And this is mentioned for the crude one. The crude one, all actually did not cross 11 time point difference. Point score, 11 point score. But the adjusted one, there's one time point, it crosses. But I think overall it shows a kind of a consistent result of non-inferiority of physical therapy compared to surgery on IKDC.
And for the secondary outcome, the radiographic images, they got 222 images from the subject, and they assessed the ORCIS-COM from the images to see the progression of the OA. They found that it progressed at least 1 point in 61 patients in surgery group and 63 patients in the physical therapy group. So also they found a mean progression of 1.1 in the surgery group and 1.1 also in the physical therapy group. However, this result was not significantly or clinically meaningful for the study. They mentioned that they put the supplement to present an overview of radiographic outcomes in the test in the supplement 2, but when I checked, there were no radiographic outcomes in the supplement. So we cannot go and see actually how the progressions of the or see some score based on the images. They also found that no significant difference between three groups in progression of the RC sum OAR SI sum score baseline to 5 years. Yes. And then for the symptomatic knee OA, they found symptomatic knee OA in 6 patients, 4 in surgery group and 2 in the physical PT group. Also, they mentioned about the radiographic outcome, but there were no radiographic outcome there for us to check. Also, they include the additional reported outcome, patient-reported outcomes that include the pain, general physical health and quality of life. However, the result was not statistically significant. So from the result here, we can say that the PT, physical therapy was not inferior as compared to the APM.
So, Samara, do you have the as-treated analysis of the three groups?
The what, bro?
As-treated analysis.
No.
It's not presented in the paper.
No. Even not in the supplemental content.
Yes, unusual.
Yeah. So can we move? Are we finished on this one? Or anyone to add something? Maybe I missed in between? All right, shall we proceed to the limitation of the study? The researcher of this study have mentioned that there are 6 limitations in their study, which delay arthroscopic partial meniscectomy. Not all patients experience satisfying result following physical therapy. They also don't have any registered patient reason for not responding to the questionnaire or invitation follow-up. Maybe it was due to the COVID pandemic. They're using the validated measure of OA of radiographic images instead of MRI due to the cost burden on patient. Remember that this study was paid by the patient health insurance, not supported by the study. So they option for the cheaper radiographic images instead of MRI. So that's why they put it as not as a primary outcome. They also don't have a register for a non-invasive additional treatment for knee pain. They also have selection bias due to lost follow-up. But however, they accounted that by using randomization, similar distribution of missing data, and use mixed model analysis of maximum likelihood estimation. Then also they don't provide the number of patients screened at the beginning of the study. Suggestion and discussion. In the paper, this study reported consistent finding as compared to other study done by other researcher. So when they compare the IKDC patient reported knee function, so they are quite similar from other study. However, when compared to other study like CAT-L study and Bird et al. Study and Sorensen et al. Study, this study has a 32% lower of crossover rate among the subject as compared to CAT-L study, but however, it's higher when compared to Bird and Sorensen, roughly around 20 and 25%. But at the same time, when compared with the CAT-L study and Bird or Sorensen study, this study have a finding that was consistent with the other study, which the data found no significant difference in radiographic deterioration between both treatment groups. Adjusted confounding effect on patient characteristic found that no supportive evidence to have possible subgroup of patients who will benefit more from surgery compared with physical therapy. In this study and when compared with other study, they also put a confounding factor of a patient characteristic, and they found that no subgroup of the patient can benefit more from the surgery. However, the researcher also suggests for future research to support the evidence where they need focus on facilitator and barriers for the implementing arthroscopic partial meniscectomy. So in other way, they want to see how efficiently to remove the APM surgery in the hospital. They also suggest to pull all of the data using individual patient data meta-analysis, which this method will provide more reliable result to support this evidence. They also suggest to have research related to effectiveness of exercise-based physical therapy compared with a wait-and-see policy or no treatment at all. They also suggest to have non-responder to exercise therapy are randomized into a surgery group versus a radiofrequency ablation of the genicular nerve root. So this one is quite complex for me actually. Number 4 suggestion for the research. Anything someone or anyone would like to comment on this one? From my opinion is that this study, the finding of this study support the evidence that to use the physical therapy as the treatment for the degenerative meniscus tear as compared to APM. Even the Dutch government also has embedded this result in their guidelines. Actually, it mentioned in the paper. Conclusion for this study is stated in the paper that exercise-based physical therapy was not inferior to arthroscopic partial meniscectomy over 5 years related to IKDC or the self-reported knee function. The researcher also observed a small and comparable progression of knee OA in the both group. However, it was not significant. Finding from this trial further support the recommendation that exercise-based physical therapy should be preferred treatment over surgery for degenerative meniscal tears. Okay, before we go for the appraisal, anyone has something to add on or to comment or to ask?
So Rana, I think the table 2 show the both intention to treat and as treated analysis. So
Yeah.
yeah, do you see that?
Yeah.
Yeah. So it actually shows a significant difference, but the point difference are less than 11. The
Yeah.
pre-decided clinical significant difference did not reach that scale of difference. That's why they concluded that the physical therapy is not inferior to surgery.
Yeah.
Yeah, you see
Yeah.
that?
Yeah.
Mm. So if the study has not pre-specified the minimal clinically significant difference, then you may go away saying that one intervention is better than the others. Yeah, like in intention to treat, you see that it's actually the surgery is better than physical therapy
Yes.
at the 3.8 point difference. Even the 95% confidence interval is 0.8 to 6.8. This even not crossing the 11 lah. Yeah. But in the as treated you can see that there are two comparisons. One is surgery compared to physical therapy. Surgery still did better, but the point difference is 2.2. Yeah.
Yes.
And the delayed surgery is not better than physical therapy. Yeah. So the difference is all actually very small lah, according to the pre-specified 11 point on the IKDC. And whether this 11 point is something that is acceptable to us is totally that has to be decided by our own practitioner and researcher. Because this, I believe this knee function score has been decided by the expert and patients based on the experience and their earlier research. This difference, when patients experience this difference on IKDC, patient would feel significantly different in terms of the knee function. Yeah. So this has to be decided in every culture or practice.
Shall we move to appraisal?
Yeah, sure.
Okay. For this critical appraisal, I use JBI critical appraisal for RCT. There are a set of questions. There are many other tool or checklist you can use, but I think for this, I will use this JBI critical appraisal. Question number 1, was true randomization used for the assignment of participants for treatment groups? I would say yes, because in the paper it mentioned that they randomized the patient by using online by using the software, if I'm not mistaken, with the 1-to-1 ratio and up to block size of 6. And then they stratified to by hospital and age. Are you agree, Paul?
Oh, yes.
Okay, question number 2 was allocation to treatment group. I'll say no, because only the radiologists were blinded, and the rest, the clinician, the patient, and the staff were not blinded. So they are subject to bias, for the allocation, and they can expect what's the treatment or intervention for the subject. So they may affect their service or the treatments or the service delivering during the study. Yeah.
Is allocation not concealed, or is it not clearly described?
Not mentioned, I think. Not mentioned. It only mentioned in the paper that only the radiologists were blinded.
Yeah, that's the blinding. The randomization itself, is it concealed? It's two
Not
different things.
not mentioned actually.
Okay. Perhaps it's not the full study protocol. Maybe the full protocol may have some information about that. Because the concealment, meaning to say, the persons who are involved in allocating the patients to the group, right? They are blinded or concealed. The randomization cannot be suspected of what come next, that kind of thing. So usually the one who is assigning the patients to the group would not know what is A, what is B, that kind of thing.
Yeah.
The blinding they cannot do, like something psycho education, that kind of thing. You know that if you got a surgery or got a physiotherapy, right? You cannot be blinded. So the physiotherapists or cannot be blinded that they know these physical therapy patients, and those who undergone the surgery also they cannot be blinded because it's actually so obvious.
Yes.
Yeah, but good things that they blind the outcome assessor lah. At least the radiographer or radiologist. The IKDC, the IKDC is administered by patients themselves, right?
I didn't found anything related to that, bro. Saying that.
Is it interview by interview or is it by self-administered?
Mentioned in the paper either it is hard copy or the online, because it's during COVID pandemic. So I think it's by self-administered.
Yeah, I think so. But it can be more clearer, isn't it? It can be
Yeah.
clearer described that this is self-administered questionnaire. But I think it's self-administered. They did something like they have to call back the patients if they miss some item.
Yes. Yeah.
Yeah, so it's self-administered lah.
Question number 3, were treatment groups similar at the baseline? I would say yes. The number is quite similar. Mean also. Were participants blind to treatment assignment? No. As you mentioned
They cannot be blinded.
Yeah. It's obvious. Question number 5, were those delivering treatment blind to treatment assignment? No. Were outcome assessor blind to treatment assignment? Yes, only for the radiologists.
The secondary outcomes.
Yeah. Were treatment group treated identically other than the intervention of interest? I would say yes. Do you have anything, Prof, to add on?
No, it's okay.
Okay. Was follow-up complete, and if not, were differences between group in terms of their follow-up adequately described and analyzed? Actually mentioned in the protocol, but no result on the analysis. Actually, this one is screenshot from the protocol. They deal with the missing data. They will be dealing with the missing data and analyze using MCAR, but it was not reported in the paper, in the article. But I'm not sure either they are actually they report the numbers of the missing or patient that are lost to follow up, but they didn't have anything, result or analysis on that.
What do you think about the intention to treat? that they conducted.
Intention to treat. What do you mean, bro?
The paper, when they conducted the intention to treat, what were the numbers that were included in the between group comparison?
I forgot. Do you mean that you mean this one, bro? Total number? Last?
In
It's 159 in the APM group and 162.
no, this is the flow. In the final analysis, intention to treat, if you understood it, is actually they maintain all the included patients in the group from baseline in the final analysis. So they actually maintain all the patients, and the one thing that they are not clear is whether they impute the missing data or
Yes.
they replace it with the last value or that kind of things.
Yeah, that one I'm not sure because there's no statement mentioned about that, bro.
Yeah.
Question 9, were participants analyzed in the group to which they were randomized? I would say yes, because they have two analysis, intention to treat and as treated analysis.
Mm-hmm.
Number 10, were outcome measured in the same way for treatment group? I would say yes, because they have same tools being used and also analysis done to the groups.
Radiologist was blinded.
Yeah.
Yeah.
Were outcome measured in a reliable way? For primary outcome accuracy score, I would say yes, because it was tested before by the researcher with the interclass correlation of 0.95. And the minimum detectable change was 8.8 points. What's the appropriate statistical analysis used? When we went to the protocol, it mentioned initially that they will use generalized estimating equation following longitudinal analysis, but later on they changed to the linear mixed model analysis. Also, I didn't find very detailed information about the statistical analysis used in this paper, but I found in the other paper. This one is a screenshot from the other paper. Actually, I'm not sure this is ethical or not ethical, Prof, because under this study, they publish many papers, which they include the IKDC score as the primary outcomes, and the difference between the paper only for the secondary outcomes. You can find other 3 or 4 papers which has same primary outcomes reported, but difference in the secondary outcome. Is it acceptable, Prof, to publish paper like that?
If you're sure, then this is salami publication.
Yeah.
If you're sure this is the case, usually they don't committed that kind of a crime, that kind of mistake.
This paper, they have at least 3 same outcome measure reported.
Is it the one at 2 years at different time point?
Same, it's all same.
All
2
same?
years.
Oh.
Yeah, all same. Yeah, one is, the difference is only on the secondary outcomes. The other one is on quality of life. Like for this paper is on radiography images. The other one is on the quality of life, cost effectiveness analysis, and the other one I forgot. But at least 3 papers.
Cost effective is different, and they can produce different paper on the secondary outcome, provided they have a clearer descriptions on the secondary outcomes and limitation of secondary outcomes, all that lah. They
Only the
shouldn't,
same is the primary outcome.
yeah, they shouldn't publish more than one on the same primary outcomes at same time point. That would be salami practice lah. You know,
Yes. Yeah.
it has to be 2 papers has to have a substantial difference in outcomes and results, and you should not publish very similar in 2 different papers lah.
Yeah. But for this paper, I found that it's not very clear the statistical use. But in other paper, I found in the same study and the same group of the escape study, they put quite a detailed information about the statistic analysis. Like for example, like here.
Yeah. And between GEE and this mixed model is actually better because
Yeah.
it can account for, and the missing data are also included in the final
Yeah.
analysis compared to GEE.
Yes. Yeah.
Perhaps when perhaps when they proposed the protocol, they never thought of when no,
Yes.
but I'm not sure exactly the reason, but the change is for the better lah.
Mm.
Yeah.
Okay, question number 13. Was the trial design appropriate and any deviation from the standard RCT design accounted for in the conduct and analysis of the trial? I'll say no.
Why?
So I think they follow the standard RCT design, and then they report the study also following the consort guideline checklist. They
So
include the randomization, the crossover, so it is follow the standard RCT design.
or any deviation. So there's no
Yeah.
deviation now
Yeah, on the design.
for the conduct. But just now the deviation from GE to MM.
That one is the deviation for the protocol. Later on, next page, I will discuss on that.
Okay.
This one. For overall appraisal, I will include this paper for consideration to accept it as a scientific evidence. But I would like to put comments. For number one, it is stated actually in the paper, not this paper, but from other paper under the same roof of escape study. They have redundancy in reporting the outcome in two other articles in different journals. Like I said before, the primary outcome, it was the same. Number two, inconsistency of reporting between article and protocol. It was mentioned, this deviation was mentioned in other paper, not from this paper, that it has error reporting in the protocol as loss of follow-up of 10%. When I try to calculate, I read the protocol first and I try to calculate the sample size, I didn't get the 160. And later on, when I read other paper, then I know they changed to 20. So, it's quite hard for me to check on that one.
Okay.
20%, and then they change the standard deviation from 20 to 10 points. Other paper, they from the crowd paper, they use the standard deviation of the population of 20, but later on they change to 10 after 1 year of the study. They get, the result of 1 year study from the subject. So after power calculation, so they adjust from that. So instead of 400 something participants, they have reduced their number to 300 and something for 2 arms of the study. So they reduce their sample size. They also changed their statistical analysis, as I mentioned in the previous slide, from the generalized estimating equation, changed to the LMMS. And there are two other things that I would like to comment, that the result was not reported in the article. Example, they mentioned they did the quality of life score, but no result in the paper. Also, they mentioned about the radiography or C score in the paper should be attached in the supplemented document, but there also no information on that.
Do you think the difference here, the discrepancy here, is it for better or for worse? No, they are doing something suspicious or they are doing something better?
I don't think it was suspicious, but I think they didn't report because of maybe it's not significant, the result, and they think, or I'm not sure, I'm thinking maybe they publish in other paper,
Yeah.
Yeah.
You were saying there's another paper on quality of life.
Yeah. But I didn't check on detail on that because they also have some other parameters and different questionnaire other than this quality of life.
And the two thing, the item number 2 that you mentioned here, I think is something like you want to be more cost efficient. So is something like adaptive design. If you know that your study will not see a large or larger than expected discrepancy or differences between the two groups, you can save on the sample size. I think that's what happened. After they found the follow-up is better, and then the SD is smaller, and they stop recruiting more patients. So they got less patients, and less patients were subjected to surgery. Remember, one of the group is
Yes.
surgery. So they kind of reduce the numbers of patients going for surgery and the cost involved in the surgery in the trial lah. Which I think, if it's truly so, if the SD is true, the loss of follow-up is truly low, then it's good. It's better rather than you stick to the
Yeah.
protocol and you have to include unnecessarily more than needed study sample lah.
Yes.
They
Yes.
need
Correct.
something very dynamic actually. That you are there enough to to make a change, but in the right way to the protocol.
I think the researcher knew what they were doing, so they planned well actually. That's what I can see from this paper.
Yeah. Okay.
Yeah, I think that's all.
Okay. My last question is: would you apply what you learned from this paper into Malaysia setting?
I would say yes, because following the result, even though it is not clinically significant, but it still have some improvement on the score of the knee functions in the patient. So at least if you cannot change for something, improvement would be better. I would say that I will try to do in Malaysia and see how it change, either it give any impact on our setting. But I think I will need to read other papers so the cost effectiveness to see if the treatment give any good things for the patient in terms of the cost burden to pay for the treatments or the effect after the surgery.
There are a few things that we are not so sure is that the measures, the IKDC, whether something that is routinely done
Mm.
by our in our orthopedic practice, and the baseline condition of the patients, and the outcome measures the difference, right? So the difference between the groups is actually less than 5 points, but according to this in Netherlands, they take it as 11-point difference as something significant. So the 3 and 4, as reported in from this study, it looks really small lah, but whether this is something that is also considered to be a small difference between the two groups by our Malaysian patients, I have no idea. So in this kind of situations, then we actually require uh, the orthopedic surgeons or the physiotherapists to tell us, the radiography one we can tell lah, is truly like just 1 or 2 points, isn't it? So it's really no difference. But we really need to hear from orthopedic surgeons, physiotherapists, and on their experience with patients. Whether in this group, selected group of patients, not really serious, without any trauma to the knee, the physical therapy should be done because it's actually less invasive and have similar outcomes. Any comment from the floor on applying this to our Malaysian setting and practices? If we could actually measure, with those tools, and we found that eligible patients as what is being done in this study, according to the eligibility criteria, so the patient should go for physical therapy, provided the physical therapy or physiotherapists had that kind of how many sessions? 16
16,
sessions.
16
Over,
session,
yeah, 16 sessions over 8 weeks,
8 weeks.
about half an hour, right?
Yeah.
So if you have the kind of also physiotherapists or physical therapy regimen, then we can really send patient for that. Telling them no need to go for surgery. You're doing fine. You'll be doing fine. Similar, yeah, that kind of thing. Yeah. So is there any comment? Anyone? Rob, Niza, can you say something? Or is there someone from radio? official? Yes? You can put in the chat box. Is there anything in the chat box? No?
No question.
Okay. So perhaps so we can't actually really apply the evidence from this paper until we have some input from our two important colleagues, the orthopedic and also physiotherapy, isn't it?
Yeah.
Okay, right. So I think that's all from me, Sawana. You have chosen the next paper to appraise for the next MJH?
Not yet.
Do you want to do that? The one I suggested in the cram?
Yeah, yesterday you proposed something.
Yeah, in the kind of the assessment of the impact of funded projects. Something about it's kind of meta research lah, or assessment of the impact or outcomes of a funded project, isn't it?
Yeah.
Yeah, perhaps that would be
Sure kan?
something slightly different, kan? And
Yeah.
perhaps something that I think our colleague Faiza is doing, or maybe Azifa also is doing something on the statistical part. I mean something that about meta research lah. That's meta research.
Okay.
Yeah.
We will meet again in lebih kurang 2 months time, bro.
Is it 2 months?
Yeah. Our last MTH was in in July.
Now it's September. Next month, isn't it? Or November?
November, yeah. Because we have changed our frequency of our MGH from every month to every 2 months.
Oh, is that so?
Yeah.
Okay. You want to show that to those audience, those who are still around? If you can,
Wait,
show that paper. Yeah.
Iman boleh share? Sekejap ya. This one ya, bro?
I think so, yes. Yeah. Research funding impact priority setting. Okay. Right. So I think that's all from me. Sawana, you have any last comments? Or
No, I think I finished already.
okay then. So if there's no last comments from the floor, thank you for joining us. Hope to see you again. Yeah, if you have no more comment, then I think we'll end here.
All right. We will update on the dates for next MJH 13. So stay updated with our email and our CRU updates later on. Thank you.
Thank you. Bye.